minutes, see if we can get hold of more just of the Vancouver sneeze, um, and uh, and then we'll decide how we're going to proceed from here. Thanks. Sorry for the delay. And if possible, just because we're waiting for the other sneeze, I don't think at this point right now we need to be recording anything. We're just recording dead space. So
A very quick overview of how registration works in the Cerner world. So I will go through the two main things is encounter types and medical service. So I will talk about the definitions and some terminology in Cerner. So first of all, what is encounter? So encounter is kind of like a new terminology come with Cerner. So basically, encounter is a single patient interaction or specific visit to the health organization. So usually in registration world, we refer it as episode of care. So in Cerner, an encounter is always required before any kind of orders or result can be attached or any kind of documentation to be dictated as well. And also to schedule an appointment, it need to be linked to an encounter as well. So each encounter will have an encounter type to associate with it, which I will talk about in the next few slides. The reason encounters are very important is it basically records all the clinical activities associated with the patient for many, many reasons like clinical, legal, administrative, research, reporting, and other purpose as well. So here are some encounter types we have in Cerner. So first of all is referral. This is probably the most straightforward one. So the same idea as a regular referral you will receive. So when a patient is referred into a health organization for appointment or service, then there is a referral encounter will be created. So any of documentations can be associated with a referral, whether if it's scanning or like faxing, and then the health organization can triage the referral. So as you can see whether they want to accept the patient or not. So if the patient is accepted, then it will be changed to a pre-registration encounter type. So the next one I will talk about is the recurring encounter type. So the pre-recurring is just a pre-registration encounter type for recurring. So the recurring is a kind of like an outpatient encounter class, but it will stay open for a period of time. So usually recurring encounter type will allow user to associate multiple outpatient appointments to the same encounters. But to use recurring, you do have to meet a few requirements. So it has to be a series of outpatient appointments that's scheduled for the same reason. And usually you need to have a defined cycle of outpatient appointments to have at least two or even more. And there should be no more than 14 days between those appointments. So in BC cancer, usually say chemotherapy or radiation therapy are allowed to use recurring encounter. For patient and family counseling, based on what I heard from the requirement gathering session last time, it sounds like you guys do have like group sessions that happen on a regular basis. Is that correct? for Vancouver or other centers as well?
They might, yes. Yeah. There might be series of sessions for group, and also there's ongoing for music therapy right now, twice a week.
Twice a week. Okay. So yeah, so for those group sessions, because they do meet the recurrent encounter type requirement, so that is okay for you to use recurring encounter type for those.
Can I ask a question there? So we see people individually mainly.
Yeah.
Can you use recurring for people that you're going to be seeing on an ongoing basis rather than having to do a new encounter every single time?
So when you say you see patient individually, it's more depends on what's the frequency you see the patient. I would say as long as if you see them within the 14 days range of time, then you're allowed to use recurring. Say if it's the same patient, you're seeing them for the same reason, then within 14 days, you are allowed to use it. If not, then it will be the outpatient. So are you seeing those patients on a regular basis?
Sometimes it would definitely be within 14 days. Other times it may be a little longer than that in between appointments.
If it's more than 14 days, then unfortunately you need to use the outpatient encounter type I'm going to talk about next, because we do have very specific requirement for recurring. So it's more for also for billing purpose as well. Otherwise, you won't be able to capture those visits accurately. And so also on the other side, that's why I say so recurring has to be used in conjunction with scheduling as well. So the details will be captured in the scheduling side.
So yeah, sorry, I have a quick question.
Yeah.
For a recurring encounter, does it have to happen on the same day at the same time to be a recurring encounter, or can it happen at any time repeated over the 14 days?
Anytime within the 14 days. So it doesn't have to be always on Wednesday, 9 o'clock. I assume that's what you're asking. As long as it's, say, within the next 14 days, you're seeing the patient again, then you're able to fit.
Perfect.
I have a
Thank you.
question.
Yeah.
So to determine whether it's going to be a recurring event or not, can it be determined after a first initial assessment session? Do we have to enter it right away, or is it something that we can do after first assessment session, and then we know better at that time period of time?
Yeah, some clinic does do that. So for those, I will suggest just like for the first appointment, you will still book as outpatient. Then once you know patient is coming back, will be coming back on a regular basis, then you can use recurring.
Okay.
So the first assessment, just like still you book just like one time, because you don't know at that time yet if patient will coming back on a regular basis or not.
All right. Thanks.
Yeah. Any more question about recurring? Okay, no. So I'll move on. So next two is pre-outpatient and outpatient. So like I said, it's similar to recurring. They are both like in an outpatient encounter class. But for outpatient, it's more just like one-time patient visit to the health organization and that do not require inpatient bed. And that outpatient will be kind of like automatically discharged at the middle of the night. So usually, say, for in-person visit with a provider or clinician or like follow-up appointments, all those one-time visit will be outpatient encounter type. And pre-outpatient is similar as pre-recurring. It's just the pre-admission type for outpatients. So next slides are a few telehealth encounter type we have. Because now we know because of COVID, a lot of care is provided virtually over the phone or through video technology type. I'm not going to talk about too much detail, but the main because you do see we have a few encounter types. The main difference between the telehealth encounter type and the phone consult encounter type is which technology you use. So if you use a video technology like Zoom or Skype, it will be telehealth. So if there's video involved. If it's purely over the phone and you provide a phone consult to the patient, then it will be the phone consult encounter type. Phone message is more informal conversation, and there is some decision still going on that encounter type may going away. So just FYI, that may be the case if you don't see it by the time BC Cancer goes live. Okay, this slide is the kind of like overall encounter strategy recommendation we have for BC Cancer. Because patient and family counseling do fall into the allied health service category. So this is a recommendation we give. So if allied health clinician is providing care, so they can, if patient has a open inpatient, say you're providing consult to an inpatient in Vancouver Center, or the patient have a chemotherapy encounter, like recurrent encounter open already, and they're using it kind of like in a joint appointment with med-onc or rad-onc, you can document on the most relevant encounter. So you can document on the inpatient encounter, or you can document on the recurrent encounter. But on the other side, if you're providing your own treatment or own service, then you can have a separate encounter, like outpatient or recurring. Say, if a patient just coming for group therapy or music therapy, then it can be your own recurring encounter. But if they come in here just for like, say, the initial assessment you were talking about earlier, then it could be a outpatient encounter. So as long as you're still meeting the requirement for recurring, like those group sessions, you're able to use recurring encounter types. I know sometimes patient and family counseling may see a family member. So if you're seeing those family members, they will need their own outpatient encounters. Does this slide make sense? Any questions?
So just to summarize all of that, are you saying, Celia, that either we attach a patient family counselling encounter to an existing medical encounter, or we create a new one?
Yeah. So if, say, you're providing service, say, for the inpatient, you can just kind of like utilize the existing encounter without creating a new one for your own. But say if patient don't have anything else going on, or they come to see you purely for something more on the psychology side, then it will be your own encounter.
Celia, this is Ira here. The 14 days, is that across the Cerner everywhere? The 14 days definition?
Yes. So that's pretty much how it works in other health organizations as well. So we kind of like try to make BC Cancer to work a similar way as other health facility, like say St. Paul PHC. So if a allied health seeing an inpatient, they will utilize that inpatient encounter as well. So if the patient come more to directly to an outpatient clinic setting, then they will have their own outpatient or recurring encounter. So it works very similar.
But it's always 14 days. There is no, say, cycle that maybe works better for PFC, for recurring events.
How to say? I know this idea of encounter is kind of new to BC Cancer. You may say, okay, yeah, it may be working better for like a more like inpatient, like large health hospital may work better in that settings. But I would say it will help BC Cancer down the road. I know because everyone is going to be on Cerner now, so having encounter is just being very helpful to help you identify which encounter belong to which clinic, because patient could potentially go into multiple health organizations and go into multiple clinics during the same period of time. So having an encounter really able to help you identify which encounter belong to your clinic, which encounter belong to other health organization and other health clinicians.
Okay, thank you.
Yeah, thanks. Okay, any other questions?
So Celia, just to clarify that, if we didn't create another encounter, what's the implication of that?
It's more like you don't, are you saying just like if you do not, there is no existing encounter, or you just document on the most relevant encounter?
Yeah, so if we were say just using recurring constantly, just somebody that we're seeing, as opposed to creating new encounters each time, if it's beyond say the 14 days, what is the implication of doing that as opposed to just continually using the recurring encounter?
If you still fit into the requirement and you can still use the recurring. So implementation is just more on the billing and the stats side. So say if you do not have your own encounter, or say like let's say if you're supposed to create one but you didn't, then you just lose your credit for that service. So you don't know, okay, patient came in at this day at that time, and what service did you provide for that patient? So you lost track of that visit, like all the information.
So it would have an effect on our statistics if we're not creating encounters.
Yeah.
Okay.
It's more like stats, or billing is more for the health organization side.
Right.
Yeah.
Thank you.
Thank you. Okay. Oops. So I mentioned briefly a little bit. So in Cerner, we do have auto discharge. So it's saving clerks time a little bit. So for outpatient encounters, they will be auto discharged the day next. The day after the registration date, but it will be backdated to 2359 on the registration day. So outpatient encounter, phone consult, or telehealth, they will all be auto discharge with a discharge disposition as system discharge. So on the other side, referral and recurring need to be manually discharged. So that part need to be either like a verbal or a system order. I believe later in the demo you will see you can place in an order to discharge for the recurring encounter. So next is medical service. This is also kind of like a bit newish, a new idea to BC Cancer. So what is medical service? It's kind of like used to define what kind of patient service the patient is received during their time at health organization. Although it is not really for billing purpose, but it is a required field in Cerner. So it really helps to help user to identify which encounter is the correct encounter for their visit. Because like I said, many health organizations and hospitals will be on Cerner down the road. So patient could have potentially multiple encounter open at the same time. Having a medical service just really helps to identify which encounter is for which service. So your service won't be mixed up with other service at BC Cancer. So this is a kind of like a big list we have for all the medical service we currently have in Cerner. So as you can see, it's pretty big. We picked a few medical service that we think is kind of like suits the service that the patient and family counseling provides. So the ones we have is we think about social work, psychology, and psychiatry. Because we don't have a medical service for counseling, so it kind of like fall under the psychology category. So this is more question for the BC Cancer Vancouver Center. Do you think all three would be applied for your clinic, or do you think maybe just 2 psychology and psychiatry will be enough?
I'm not sure. I want to honor also the clinical counselors, but also the social workers, because we all share the same role definitions.
Yeah.
If that means that clinical counselors will fall under psychology and social workers under social work, psychiatry on its own, then maybe that's the way to go. But I wonder if we can actually add the clinical counselors in that list.
I know there are some discussion going on about whether we can add that as a medical service, but for now, psychology is the one we have, unfortunately. But sounds like for now, so those 3 will be able to work. So you can just each group will have their own medical service to help them to identify which patient belong to which clinic.
What are the legal implications of that? If a clinical counselor is going to be signed under psychology, is there any clinical legal implications if they sign any off this way?
It's not. There's no legal implication for medical service. It's more for identification purpose. So later you may able to see in some Cerner screen. So when you do the encounter search, you may see more than one encounter. So it's more just kind of like help you to identify which encounter belong to who. It's that part is not really for billing or like other legal implication. It's more just like a system identification, so we know which encounter belong to which service.
I would argue that this clarification would be important because for our medical colleagues who may be going to have different expectations of what psychology may be providing, but in fact it's clinical counselor, and what social workers are doing, it may be confusing for those who don't know.
Oh, yeah.
And have different set of expectations of what we do.
Okay. Yeah, it's so it's good to know. Thanks for the feedback. I will bring that back to my team and see if we can add counseling if it's possible.
Thank you.
Celia?
Celia, earlier on, Stephen was talking about making it social work / counselling. Counselor. Could that be done in this instance too, or is this an enterprise-wide list here?
It is an enterprise list. That's why I can't just say on the spot say, okay, I can change this. Because the thing Stephen talking about, I think it's more flexible in terms of configuration. They can just change it. This list, although my team maintains this list, but we don't decide which medical service can be on this list or not. it need to be approved by a higher up in CST and the clinical side as well. But I can definitely bring this back and see if we can change it to, if it's possible to change it to psychology / counselor. That might be a good choice.
Social work / counseling.
Oh, social work / counselor?
Yes.
Okay.
Yeah, Celia, Steve here. I agree with what David and Irina are saying. Like, if we could possibly change it to social work / counselor, that would be the best of both worlds. Psychiatry, I don't know how David or Irina feel, but psychiatry is usually related to psychiatrists, which is a medical profession, and psychology, there are actual psychologists. And that's usually kind of the one-to-one relationship there.
Okay.
So if we could possibly modify this medical service, and then the thing is, if we could modify social work to be social work counselor, that would actually work across enterprise in not only BC Cancer, but in all areas in VPP, being Vancouver, Providence, and Provincial Health Services.
Okay, that's good to know. Thank you. Okay. All right. Yeah, I will bring that back for sure. Thank you. All right. Next slide is, so in Cerner we do have different applications. So later on in the demo you will see kind of like all three of them a little bit. So the main one for registration staff going to use is called PM Office, and the one scheduling clerk use is called scheduling appointment book. So when they book appointment, they can actually go through some registration conversation as well. And the Power Chart is an application that mainly the clinician use, but they can also access some registration conversations through the Power Chart as well. So later you will kind of like see how those three applications kind of like work together. Okay, back to you, Stephen.
Thank you. I'm just going to take control back here. All right. Excuse me. So what I like to do is just a really high level overview of the workflow for the patient and family counseling clinic. So if you see on the screen, what happens is internal and external referrals are received by the clerk. There's a triage done, and I wrote by the clerk or by the clinician, but in a clinician-led clinic, typically all triage is done by the clinician. If the clerk is doing, quote unquote triage, it's typically not triage. It's a different workflow. I'm going to go over this today, explain a little more what I'm talking about, but for right now I just want to stick to the high level overview. From the triage, the clerk will then book the appointment or schedule the appointment, the day of treatment. If it's in person, the clerk checks the patient in. If by telehealth, because the patient technically bypasses the clerk to meet the clinician online, the clinician will check the patient in. The clinician then will review the patient information, complete their assessment and treatment. This doesn't necessarily apply except for the follow-up orders, but the clinician can place lab orders, and completes their documentation, places follow-up order, and the clerk books the follow-up as required. And I'm just going to go pointer here. One sec. So let's talk about this first part, which is the referral intake. Going back is this part right here. So referral intake. So in the world of Cerner, there's two types of referrals. And actually, it's very similar to what happens at BC Cancer right now. There's an internal referral, and this means an incoming referral from a VPP, so Vancouver, Providence, or Provincial Cerner site. This may include referrals from other hospitals and sites that are live, if appropriate, and involves the use of electronic referral orders. Previously, I was going over that with David and Carolyn there of what an internal referral order looks like electronically. An external referral is an incoming referral from a non-Vancouver, Providence, Provincial Health Services Cerner site, and involves faxing a paper document to the clinic. Very similar to what's happening now, with a twist, and we'll go over that twist. So let's talk about internal referrals first. Essentially what happens is a referring provider, or I should say non-provider, places a referral order in PowerChart, and the clerk receives this referral request in Chatbook. The referral looks something like this. So this is the actual referral to patient and family counseling. What we have here is a scheduling priority. So that's looking at the time this person should be scheduled, as the person who's making the referral believes it should be scheduled. So anywhere from 24 hours to, I think, a couple months is the scheduling priority. There's a number of choices there. Requested provider. This is only filled out if the referrer, a person who's making the referral, wants this patient to see a specific clinician in the clinic. This is not always filled out. Usually I find this part is completed if, say, if I was a physician and I was talking to a patient family counselor in the clinic about referring a patient to this clinic. I've already discussed this patient with, so we'll use David as an example, and then because I've already had that discussion with David, I would put David's name in here. Reason for referral, this is free text box, and they could indicate the reason for referral. Is an interpreter required? That's a yes, no, or unknown. Visit modality, what we're discussing there is how the patient or the person who's making the referral is asking that the visit takes place. Could be by phone, virtually, or in person. The location, so what site is this taking place at, or the referral is going to, I should say. Right now, it just says paper. In the future, it will say BC Cancer Vancouver, and then as each BC Cancer site goes live, we'll be adding more locations to this box right here. Any special instructions that the person who's making the referral has to the clinic.
Stephen, I have a question here.
Sure.
So I've just noticed in the language of orders, order comments, and order for signature. So if another provider places this referral, I just worried a little bit concerned about, again, expectations as opposed to our clinical judgment in terms of they may seem that this is an urgent referral, but after our triaging or assessment, we may not see that as urgent, or things change, or even the reason for the referral changed. I just want to clarify in terms of kind of expectations of the other healthcare providers and our own autonomy to determine the actual reality of when the person is going to be scheduled and what would be the reason and how they are going to be seen.
For sure. Great question. This comes up quite a lot. So as a like you said, autonomous professional, it's your choice of how this person is going to be scheduled.
Okay. And
to be seen. So as working as a physiotherapist, I have received a lot of referrals where we'll say the physician has said this person needs to be seen in 48 hours. It needs to be seen right away. But when I've done my investigation, my triage, that's not the case, right? Sometimes when you actually speak to the patient as well, their concern is not, they don't feel they need to be seen in the next 24 to 48 hours. So in the end, it's always your professional judgment, and you're going to make the choice about how to schedule a patient because you are an independent, autonomous professional, and you are capable of making those decisions.
Okay, thank you for clarifying that.
No problem. Vice versa, I should say as well too. If you make a referral, say you at the patient family counseling clinic make a referral to me, the physiotherapist, in the outpatient department, you may believe that patient needs to be seen a certain amount of time, but as I take your referral in and do my assessment, I may make a different clinical judgment and book appropriately. Does that make sense?
Yes, absolutely. Thank you.
You're welcome. So,
and can any clinician within the Cerner system do an order to any other clinician, or is there a limit to the scope of who you can put these orders in for?
Okay. So, and make sure I hear you correctly, does any clinician have access to these orders? And
so, for example, doing an inpatient, asking for inpatient physio, normally that wouldn't be part of our role to do that. It would normally have to have a physician requirement or a approval, for example. But in Cerner, can anybody within the system refer to anybody else?
Yeah, great question. So, yes. So everybody has access to all orders in Cerner. However, Cerner, because we've given everybody access, we are requiring people to make their own professional judgment and know the scope of their work and what they're able or not able to do. So we don't limit the system. We let the professional use their own professional judgment about what they are capable of doing. Does that make sense?
Yeah, for sure.
Okay.
For sure. Thanks.
And just a quick FYI, David, you could refer to physiotherapy and you do not require a physician cosign because that would be within your scope.
Good to know.
Yeah. So they're probably the physiotherapist is in patients is probably going to be cursing me, but it is true because physiotherapists can refer to themselves. They don't require a physician cosign.
We actually have it working right now in Vancouver. We do have a physiotherapist who is working mostly with the inpatient unit, but she also has kind of mandate of outpatient patients, and we do have ability to refer to her if needed.
Yep, you for sure can. All right. So we're discussing this before. So all the referrals that come into the patient and family counseling center or services fall onto this future request list. Okay, and this future request list is right now it's seen by location. So location would be patient and family counseling, and this would be seen by the clerk or secretary. Okay. So this is just all the internal referrals, and they all come into this one place. And I think you asked a similar question there before, David. And as we go through this, hopefully we can answer that question. And if I don't, please let me know.
So one question about that then. So in an instance, say, where the clerk was off, and would the clinician be able to see this same list as well?
Actually, that's a great question. I want to say scheduling.
No. So unless the clinician has reg and sketch privileges, which I don't believe we're granting any for BC Cancer, or very select anyway, they would not have access to this request list.
Right. So that could be problematic for us in the instances where our clerk is sick or absent for some reason, where one of the clinicians can't actually see where the referrals are that are coming in by this means. Yeah. That could be problematic for us.
For sure. And I think this is something we bring up to BC Cancer as well too, is if a clinician is sick, clerk is sick and not available, how is the clinic going to continue to do their day-to-day work? And so this is a topic that has come up in other centers as well too. And what they've done is they've had increased their clerical staffing, so having more sick and vacation coverage, as well as having clerical staff overlap in duties if one of them is sick. So what I've seen at other sites is they're trying to compensate for when this clerk is not present. So the work can continue at the clinic.
Okay, because all clerks will have access to this.
I will just double check with my scheduling people.
Yes, all clerks have access to this.
So as long as we can access a clerk somewhere, even if they're not the appointed person, they could actually generate this or access this for our purposes.
Exactly, yes.
Okay, thank you.
Thank you, Andrew. Okay, so continuing on. So then we have the external referral. And thank goodness for the hospital system, we are keeping the fax industry still alive. So a paper document is faxed to the clinic. A clerk receives the incoming fax and appears in the work queue monitor, or WQM. Think of the work queue monitor as the electronic fax. Once they've received this fax, the clerk then places the fax document into the Cerner chart. So right now, I'm using this as an example as the fax paper form. Is this your paper form that you use for external referrals?
Yes.
Yes. Okay. So you would then see.
Well, just to clarify, Stephen, external people don't have access to this. No.
Okay. How do they fax to your clinic?
Well, there's a separate form that's for all supportive care that is more externally focused. This is an internal patient family counselling referral, and generally the referrer externally would be phoning in or emailing or whatever, and the clerk would fill this out and then put it in the lineup for triaging. But no, this is not accessible to external parties.
Oh, okay. Okay. So I think I know the supportive care referral form you're talking about. It has a number of different professionals on that form. So
That's right.
That is an example of a form that may come to you through this work queue monitor. And
Right.
To be quite honest with you as well too, because BC Cancer Vancouver is going to be going live first, and say other sites are not going to be live, so technically they're going to be external until they are brought on live, so they actually might be using this form as well too. So there's going to be probably a couple different referral forms coming through Work Queue Monitor for patients. All right, any questions? Okay. So this is Work Queue Monitor right here. As you can see, we have an example of a fax that is on the screen right here, our electronic example of a fax. And what the clerk would do, or the secretary, is they would click on this name right here, and this is Mary Hin Test. And when they click on this name, this fax would come up and they could read the fax over. So like I was saying before, as Work Queue Monitor is just an example of an electronic fax. Because it's electronic fax, we do have a design question for you. Because BC Cancer Vancouver Patient Family Counselling shares a fax number with BC BC Cancer Vancouver Psychiatry Clinic, in the future state, each clinic will require their own fax line, because we need these referrals to come in through the fax line to go to Work Queue Monitor. So there's two options. Option one, so port or take the 604-877-6249 number to Work Queue Monitor. The pro is no education for, let's say, of referring clinicians is required. The con, though, if we do this option, is paper faxes will no longer be received at this fax machine. Option two would create a new fax number for the Work Queue Monitor. Pro, you continue to receive paper faxes. The con being you'd have to educate your referring parties that the referral forms must be sent to a new fax number. So I guess one of the questions I have to help you make a decision is, besides referrals, do you get a lot of paper faxes other than referrals to your clinic in Vancouver?
Yes, we do receive paper faxes referrals for both for psychiatry and for us, and quite frequently, I would say.
Oh, so besides the referrals, do you receive any other paper faxes?
Oh yeah.
Okay. So it sounds like you're receiving other faxes other than referrals. So I don't know what would be the best option for you. This is for you to choose.
So just kind of to clarify, in both instances, we will have to change the number, the fax number.
So only in option 1. And Irina, we don't have to make this decision right now, just because Lumi has usually been involved in this decision as well, and we will be seeing her in our psychiatry design session later. But I would like to hear what your opinion is from the patient and family counseling side.
I mean, changing the number of the fax number that's been known for years and years and years to all the community partners would be tremendous shift and change for us. I would advise against that.
Okay, I'll note that down. Thank you.
If we could keep our number, that would be the best option.
For sure. I'm going to write that down as we discuss that with Lumi. Thank you.
All right. Any other questions before we move on here? Okay. CST, any other questions or follow-up questions?
Nope.
No.
One question, Stephen. So we get a lot of telephone referrals by other parties externally. That happens a lot more than fax referrals. So in that instance, currently the secretary just takes the details, fills out the paper form. That's what goes in the triage folder. How would we be doing that in this system?
So who's getting is it yourself who's getting the referrals, or is it the front desk, or both? Or
sometimes it's the clinician, mostly it's the secretary or the clerk, and some clinics have that, but it's the secretary essentially is taking that information.
So let's talk about the clinician first. So if it's the clinician, you're getting that phone referral, you could actually do the referral to electronically and just fill out that information within the electronic referral, and then sign it and then send it in.
Okay.
So that's
if it's the secretary.
Actually, just want to double check with this. Andrea, does the secretary have access to orders?
So they won't be able to place an order in PowerChart. David, my question to you is, when the clerk receives that phone call, are they booking this appointment right away, or would they, current state, say, fill out an existing referral form and then send that off to a clinician for triage?
Yeah, the latter. The latter.
Okay. So in that case, there's multiple options.
And not just a phone, but I mean, a lot of people are dropping into our offices, patients, families, and the secretary in our situation, she takes the details, fills out the form, as she does with the telephone, and then places it in triage folder. So how would we do that?
So there's multiple options in that case. You could keep it the same, where they can fill out that same referral form and they would just need to fax it to themselves so it shows up in WorkQ Monitor, and they can continue on with a workflow that Stephen is presenting. Alternatively, they could create the referral encounter while they're on the phone with someone, but that won't have as much of the information that a referral form would have.
But I thought you were saying that the secretary doesn't have the capacity to generate an order.
No, not electronically, but if you still had a copy of that paper referral, they'd be able to do that.
Oh, so once they faxed it in, they can see it as a fax, but they can't actually generate the order electronically.
Correct, yes.
Oh, I see. Okay.
But we can take that back in solution as well, and present some more options. I don't know if we're having a second design session or something that we can bring up at our validation.
Sure. Yeah, because that's a big route for us for referrals. Although, as that means that the within clinic one is also significant, but so is self-referral and external referrals by phone.
It's Carolyn here from Prince George. I just wanted to say that we pretty much never receive a fax referral, but we do, the paper referrals come up from the clinic, so that would be done electronically. But a significant, just to reinforce what David's saying, a significant number of referrals are walk-ins or phone calls, or emails are often actually as well that come in primarily to myself, but I think to the other practice leads as well. And then those need to be fanned out to the staff on intake or to the clerk to assign. And just going back quite a ways though, but to the issue of the clerk having access to that triage list, in Prince George, the clerks and secretaries rotate sometimes daily and are often short-staffed. Like the clerk department is usually down by 3 or 4. And so that means that supportive care has a clerk only very part-time and they rotate very regularly. So access to that list is going to be quite critical, I think, on how the clerking department is going to manage that, just as an FYI.
No, that's very good to know because this has kind of been an issue as we've gone through from site to site, not just at BC Cancer, but other VPP sites. And we've been really working with leadership to try to solution a way to make sure everybody does have the appropriate clerical support.
And so to piggyback on that question, we do receive quite a few referrals by emails, either directly to clinician, and you explain that, but also our secretary and our clerk would receive emails from physicians as a referral that they will be translating into the paper. But I wonder if there's any route for the emails to be attached to that QM.
So if the referral is coming in as a PDF document, there is a way to import that into this WorkQ monitor. So that is a possibility.
The email.
If it's coming in as a PDF.
Okay. No, it's usually just one-liner. Please see this one. This is kind of, yeah, just kind of refer to the name and the number chart, but not a form.
Gotcha. Okay, so there isn't really a lot of other information. They just get the patient's name and that they want to refer them to this clinic?
Yeah.
Okay. I'm just going to note that down as well for us to take back.
Laura here from Victoria Center. Just to add into what everyone else has said too, sometimes when the secretary or clerk is getting that phone call, it can also just be a voicemail message. So it can be a very simple, my name is yada yada, and I'm hoping to get some counseling, please call me back. And usually that would be translated into maybe a paper referral, and then the counselor or social work would triage and follow up. So I think there's lots of different avenues that it's coming in, and important for us to be able to have that connection with our secretary or clerk of how that information is translated.
For sure. I will also note down voicemail as another method of receiving that then.
Thanks. And Andrea, maybe this is something we'll also take back too, because we'll have to kind of think of how we're going to incorporate this into workflows and whatnot, just so that the multiple ways that these clinics get referrals can be reflected accurately.
Thanks, Stephen.
No worries. Great conversation. Any other questions? Okay. Let's go on to referral triage. So typically in clinician clinics or allied health clinics, this has been the triage workflow that is typically used. So the clerk creates a referral encounter and sets the status to ready for triage. The counselor then will review the chart and collect additional information as needed. The counselor accepts or rejects the referral. And then the counselor documents the acceptance or rejection of the referral as needed. If the referral was accepted, the clerk will convert this referral encounter to a pre-outpatient encounter and books the appointment based on clinician availability. And if it's not accepted, the clerk discharges the referral encounter. So,
sorry, Steve, are you saying that's the current state or this is the Cerner state?
This is the Cerner state, sorry.
Okay.
Yeah.
So Stephen, going back to Vancouver, for us, because majority of the referrals are straightforward and there's majority, only a few exceptions when we reject. So the secretary or the booking clerk actually been able to kind of skip the step of triage through the clinician and book directly to the tumor site. Is that going to be kind of an issue with this new flow?
So I'll get to that after, okay? I think that's a great question. I want to do this triage workflow referral first, but I do want to address that because that's a slightly different workflow. It is possible to do it, but it does require a couple things to happen. So, great question. Please hold that thought, and I will take us to that part. I just wanted to hit this because this is typically how, in an allied health clinic, we'll kind of go through the workflow here, or the triaging process. But yes, there is still, I know Vancouver, you have a bit of a different workflow, and I want to reflect that. I just wanted to do this part first. But I know there's a couple other questions there.
So can I just ask then, Stephen, are we saying in Cerner it has to be the clerk who does the booking of appointments? Is that what this is indicating? Because that rarely happens in our situation. It's mainly the clinician booking their own appointments.
Yes. So, and this is going to be I think a big change, is that for BC Cancer has made a decision that their clinicians are not to be scheduling appointments. This is not a Cerner decision. This is a BC Cancer decision. And so that means the clerks will be responsible for booking the clinicians' appointments.
Yeah, and that's going to be very problematic, especially in situations where we are short-staffed in clerical support, because that's going to be then creating quite a bottleneck in the system.
Mm-hmm. I totally agree. It's like I've said, this is not a CST decision whatsoever. This is a BC Cancer decision. So BC Cancer has made that commitment that they're going to look at their clerical staffing so there won't be any bottlenecks. However, going forward, this is the decision that's been made. And unfortunately, I have no control over it.
Okay, thank you.
No problem.
It's Carolyn here. I have a quick question.
Sure.
So on a typical day, I may have patients booked, but I will have quite a few walk-ins, phone calls, emails, requests for service, etc., etc. So I may add 10 appointments to my day. So who will, is that something that the clerks will do in future? Because I would say that typically of 5 staff in Prince George, we could have 10 or 15 changes per counselor per day in additions, etc., etc. Because say I'm looking at my case schedule tomorrow, and it's quite open, but I'm responding to walk-ins, phone calls, calls from the clinic, etc. So I just wonder how that's going to be adjusted and accounted for.
Yeah, so, and I know I've heard this a lot from BC Cancer clinicians because they're used to creating and managing their own schedules within CASE. In the future state, the plan is to have the clerks do all the scheduling for you. So if you need to reschedule or schedule an appointment, then you'll be speaking with the clerk. Now, I've heard already too that because of sounds like the clerical understaffing in Prince George, that sounds like it's going to be difficult at this point right now. But that is the decision we're working off of from BC Cancer, is that the clerk is going to be working to schedule your appointments, and as your schedule changes, then you'll be speaking to a clerk to rearrange your schedule and adding or removing people as needed.
Okay, well, I appreciate that that's the decision that's being made, but I do want to emphasize that that will be about 50 or 60 changes until we somehow figure this out differently. It definitely could be 60 changes in a day.
Yeah, and I'm getting that sense too that a lot of people's schedules are quite fluid to reflect the work that they're doing. However, all this information I'm taking in, we do take back to people at BC Cancer to just to bring up that frontline concern about how this is going to look in the future, and also the worries around adequate clerical staffing as well.
Yeah, and I don't mean to beat a dead horse, but I just want to say one more thing here, and I'll try to be quiet, is that so for clerical in Prince George, the clerks who rotate in on a daily basis bring their other jobs with them, and at best they're responding to 1 or 2 emails per day. And so this is going to be 50 requests potentially from counseling staff. And right now they're able to respond to 1 or 2 requests in a day because that's just the process. Anyway, I'm just putting it out there that I foresee that the changes may not be made by clerks. And so then what will happen, I mean, we can be hopeful, but the reality may very well be that clerks can't do that. And so then what does that mean? Or has there been thought into, like, does PFC just not get recorded in those patient charts, or, in those likely situations where there's a backlog there?
Sorry, what do you mean as a backlog? As a backlog for scheduling?
Yeah, like say they end up with 60 changes in Cerner, and they aren't able to do that, and that goes on for 5 or 6 days. Like, how will that affect counseling and sort of documentation and patient charts?
Right. There's a kind of a lot of factors here, and it's hard for me to answer that because it's, for instance, if there was a patient that already had a recurring encounter versus if they need a new encounter altogether, there's kind of a number of factors there. So it's hard for me to answer that question, like how that would look, but that is concerning that you're telling me that there could possibly be a large backlog of how people are booked and rebooked. So I don't know if anybody from the scheduling team has anything to add. I'm sorry, scheduling is not my area. I'm really just kind of learning it really quickly for all my BC Cancer clinics.
Stephen, you're definitely going down the right track in terms of documentation. It is all about the encounter strategy for that clinic. So you're right. If a recurring encounter already exists, the documentation can be done on that. And it is a whole other consideration if there isn't one that needs to be created.
Yeah, because I'm just worried that, well, one issue is that staffing, that clinicians won't be able to get notes on charts, but also that other colleagues won't be aware that PFC is involved, because I think it's a very likely situation where there's going to be a significant backlog in what needs to be updated, since counselors won't be doing that. Like, it's a nice idea to think that we'd have enough clerical support or new staff would come on board, but it appears that the ability to hire and sort of bring that in might be thwarted. And so even if that's thwarted for a month or two, or a couple of months, we're looking at 50 encounters a day that would be changed. So over 5 days, you can do the math on that. It could get quite significant. And I just want the planning team to be aware that that's an entirely likely possibility.
No, that's very good to know. Thank you for letting me know, Carolyn. And I think it's really going to be dependent on the encounter strategy. So, coming from a professional lens, I wouldn't want any charting to be lost whatsoever. If there is an existing encounter, the counselor or clinician will be able to attach their documentation onto that encounter. I didn't go over when I was going through a patient's chart, but there is a place to see any completed documentation. You click on the button and it will list out all completed documentation on that patient. I think, what you're bringing up to me right now and what I'm hearing is that when there is no encounter created, and there's a backlog of encounters being created because there's not enough clerical staff, what happens? And that's something that I think we need to address, and just kind of troubleshoot that scenario. We have been told that BC Cancer has made this decision and there will be clerical staff, but I do hear your concerns about, that's a very rose-colored glasses scenario. Is that truly going to be the reality when we come to Prince George?
And so, Stephen, am I right in saying you can't do documentation unless an encounter is created?
You can't. You need to be able to attach your
documentation to an encounter.
Correct. There is. Yes, we need to attach our documentation to an encounter. I'm going to look into, if there's not an encounter created, what is the next steps. There is a ticket out there and there's a process, but it escapes me right now. So I'll look into that. The one encounter. Oh, Andrew, do you have any follow up on that? I know there's a ticket out there and I just haven't read it yet.
Unfortunately not. I can't say that there's been any major decisions made yet as to what's going to happen if there's no clerical staff and there's no encounter created yet. So that is something that we'll need to follow up on.
Okay.
Yes, it's Carolyn here. That's a significant problem, because it's one thing to have the sort of notification of counseling staff having met with a patient, but it will be a major problem if we don't have encounters and people are getting behind 8 and 10 sort of chart notes in a day, because they won't be able to catch up by the end of a week. So I think if there's some sort of troubleshooting around getting an encounter set up.
Yeah. So the thing is, go ahead.
I was just going to add, Laura, here, just to kind of add to what Carolyn's saying. I think, if I'm thinking of our on-call shifts, they're often just broken up here in Victoria, at least, into kind of half days. And so our secretary currently is for speech language pathology, nutrition, and for counseling. So even if our secretary or clerk is here and is available to do that, them being able to do it right in that moment, I suspect won't necessarily be possible. If it takes them an hour or two, I've just responded to a suicidal patient and I need to document that, and an encounter hasn't been created, I worry that it'll be pushed beyond the actual time that person's on call for that half day. And then when are we going to be able to do that documentation? Like, there is a lot of sort of on the fly documentation that we need to do to make sure it gets into the chart, particularly for safety reasons. So just to sort of add what everyone else is already saying, I think us not being able to make that encounter and attach the necessary documentation is going to be a concern.
Yeah, and I think you know, these scenarios, when these happen, it'll be good to know, like, if there is not if there's no previous encounter whatsoever with the patient, right? So you know, we're talking about a lot of times when there's no encounter whatsoever, meaning that this patient has no contact to date with BC Cancer.
Oh, okay. So as long as they're like a registered patient in the system, it's not that they have to be known to PFC. It's just as long as they are in the BC Cancer system. Is that right?
Yeah, and Andrew, you can correct me if I'm wrong, but if there's already an encounter already created somewhere within the system, you can use that encounter.
I would actually defer that question to Celia.
Oh, okay.
I don't know if she's still on the line or not.
I am. So, like, it's more like a clinical question too. Because like technically, I think you can attach to the encounter, but it depends on whether if the encounter is relevant to the service. Say if it's like if the patient have an inpatient encounter at the center, then I think it should be okay if they attach to the encounter. But if it's irrelevant encounter, I would I think it's better to have their own encounter.
Right. So if there's a patient who's come and seen, you know, they've come and seen some of the docs, or they've had encounters with the nurses, but they haven't seen any supportive care yet, we'll be able to kind of piggyback on their encounter to be able to chart. Is that right?
Yeah, you can.
Okay.
And so you're 100% sure that that patient wouldn't have to have had an encounter with PFC, because the situation that Laura's describing is quite common, and we would want to have documentation, especially in terms of a patient who had indicated suicide ideation, on the system immediately, so that the next clinician seeing the patient, for example, at the new patient appointment for a med-onc or a rad-onc, is aware of that mental health status.
Right. So in this scenario, say the patient was being seen in another part of BC Cancer. When they were seen in that part of BC Cancer, they expressed suicidal ideation, and from that assessment that happened, you were called in. Now, if that, and Celia, please correct me if I'm wrong, if I'm going down the wrong hole. So because that patient already had an encounter and they had already seen a professional at that time who they expressed this suicidal ideation to, and they referred to you, then you could document and put your documentation on that encounter, which would be the same encounter where they had expressed that suicidal ideation. Cecilia, was I in the right ballpark there?
It's just like it's clinical, but I would say, so don't take my words for it. I'm not sure if there's a suicidal alert for you, like in the alert category. Say if there is an alert, usually this kind of thing is on patient level, so it will be across all encounters. So stay with the patient. Same as documents, I think it should be viewable at patient level, so you should be able to see all the documents associated with the patient. So whether if it's attached to a certain encounter, it shouldn't matter. But I'm not expert in that perspective, so I'm not sure if there's someone from clinical side can back me up for that.
So why don't we do this for the sake of time? I think this is a great conversation, and I think we need to take this back just to make sure I have, from a clinical perspective, the right idea of what should happen. And then I think this is a great example, and maybe we'll use this in our swap meeting just to make sure that we understand what should be happening, and then make sure that the counselors always have a encounter type to which to attach their documentation. And this is something that from a CST group, I think we should just take back and make sure we understand fully.
And Stephen, if I can just add one more quick thing, it's Laura here again. Sometimes too, so there is a suicidal example, and that would often come from in clinic, mostly for us, at least in Victoria. But there are certainly other examples where, you know, I'm getting a call from a nurse at Island who's indicating that this patient is going to need a lot of assistance. There's a falls risk and they need help with accommodation. That's just an example. So there's sometimes where we do have sort of immediate concerns for a patient that really, really should be documented for the rest of the medical team that aren't necessarily coming from in clinic. Either the patient's calling in themselves or we're getting a referral from an external source somehow. And it would be really, really important for us to be able to document that and make sure that the medical team knows. And I worry if it goes beyond the sort of 4-hour pager shift, how quickly we'll be able to get in that documentation. So the suicidal example is a good example, but there are also different avenues in which we would be getting attached to a patient that may not have an encounter where the documentation would still be really necessary.
Right. But I guess from that example, and just to double check, is because they're attached to a medical service or a medical, you said the medical team, that they've had some touch with BC Cancer, correct?
Usually, I mean, every once in a while, we do get someone who's not quite in the system yet. Like they've been maybe, I don't know at what point an encounter would be made, if it's only once they've had contact with medical providers, because sometimes we are actually the first person beyond administration to touch that patient's file. Like they haven't had their intake through nursing yet. They haven't met with the doctor yet. So there are situations where we are actually the first professional in the building that they'd be speaking with.
Right. So maybe they haven't had, and Celia, maybe you can speak to this, maybe they haven't had an appointment with another BC Cancer clinician. However, they would have, to even begin that process of having an appointment, they would have to have some type of pre-encounter.
So now the scenario, the part I'm worried about is, so there could be couples kind of like break down even a bit more to couple scenarios. So it could be the patient haven't been to BC Cancer, but have been visited to another Cerner site. Then you should be able to find the patient in Cerner. But the scenario I'm more worried about is if it's like a brand new patient, haven't really been visiting any of Cerner site yet, then in that scenario you do need a clerk to kind of register that patient. That's kind of unfortunate. But if the patient have been to other Cerner site and they have other encounters, then you will be able to find the patient in the system. And I do believe, but like Stephen need to double check, you should be able to put information on a patient level. That information should be available across Cerner.
Okay.
Yeah.
Okay.
Let me take this back and look into this and try to look at some scenarios. Well, I've heard a couple scenarios already and try to work them out and see how that will work in Cerner. So you guys have some actual practical processes that you can use to make sure your documentation is attached to an encounter. This is work for me to do. So it's stuff that I will need to know going into the future for sure. So thank you very much. Any other questions? No. Okay. So what I just want to show you here is this is a triage patient list that would be created by the clinician in PowerChart. So you would just create this list, and all the patients that are supposed to be triaged would go to this list, and you could go through each one of these and triage. So you would click on the patient. It would then take you to this summary page, and this is actually the patient chart. This patient's name is Test Allied RR Demo. And then you could actually review the chart, including documentation. And you could read all the documentation that has been done to date on the patient. Once you've reviewed the chart and read the documentation and decided if you're going to accept or reject the patient, you would then complete a accept referral or a reject referral. And I think this goes back to one of the first questions I heard is, based on your clinical judgment, you could decide as a clinician how quickly to see the patient. So either within the next 24 hours to within a year or as per special instructions, which you could fill out this information right here. Regardless, you could always fill out information in the special instructions, and really this will then go to the clerk and to update the clerk on anything that you would like the clerk to do. For example, you might say accept referral and please put in Steve's schedule to be seen within 1 week. The reject referral, there's two standard reasons why you might deny a referral, and then an other. If you clicked other, just fill in the special instructions right there. Once you have completed that, then this goes to the work list right here, and all the clerk can look at all the accepted referrals and then book appropriately. Now, I know that typically most sites don't keep a wait list. However, I know there was a couple exceptions, but there is an ability to set up a wait list database insert as you would like for your site. So I just want to put that out there as well too. Internal referrals can be just the patient could be moved over there. For an external referral, they would have to be manually put in. Now, Vancouver, I know, has a slightly different way of scheduling patients, and they don't necessarily go into triage in the typical sense. So really what the clerk looks at in Vancouver is the terminal location. So is the terminal location indicated in the referral? So I specifically put that in here because if the tumor location is located and it's obvious in the referral, then the way the Vancouver site works is the clerk can then complete the request from the request list, contacts the patient to book the appointment, and creates the pre-outpatient encounter. Now, if the clerk or the tumor location is not face up, then my suggestion it would go to triage for the clinician to review, to go through the chart and make sure it's an acceptable referral or not.
So right now, the clerk does have access to case notes, and that's how she learns about the tumor site if it's not indicated on the referral itself. So sometimes people do put the tumor site, sometimes they don't. So the clerk goes into their charts and she reads physician's kind of diagnosis, and based on that she knows what would be the tumor site. So she has that ability to find out that information right now. I agree that if they don't know for whatever reason, it's not just the tumor site, but whatever, they're pretty good with kind of flagging the concerns about whether it's appropriate referral based on the timeline. Maybe people have been discharged from clinic for a while, so they're post 18 months. So they will be bringing those concerns to the PPL to determine the triage and who is the appropriate, maybe the counselor, if they know that the counselor is booking far away and they need to be seen earlier. My question is, so who is going to, they're in the for the triage person, they would be putting when actually the person is going to be seen, and so that would be usually based on the clerk's conversations with the patient, because they will be determining based on the availability of the counselor and the patient's availability.
Right. So that conversation has to take place anytime, because even if you're doing the triage and you say, please see this patient within the next 48 hours, but you contact the patient and the patient says, well, I don't have any time in the next 48 hours and I don't really feel I need to be seen the next 48 hours, then that conversation always happens at the patient level regardless, right? Because you really have to work with whatever the patient is able to do or wants to do.
So the clerk would be able to fill out the triage form, the triage, and not the clinician?
Well, the clerk is not, I'm calling this internal referral without triage because triage is a clinical decision that you're making, and the clerk is not making clinical decisions.
Right.
Right? So I don't want to mix those two up. I also want to separate this out, not only because I know it's very specific to the Vancouver site, but also to looking forward. The clerk is going to be doing a lot more work in Cerner, and I do not know if you would want to put this load on the clerk to then, if the tumor location is not face up and easily seen, to then have the clerk start going through the documentation to try to review the documentation to find the tumor location. Because it's starting to get into that clinical sphere, and I'm at this point trying to separate that clinical sphere from the clerical sphere, especially because the clerks are going to be taking on a lot more work, and if Vancouver Clinic is assigning them more work to go in the patient's chart and to review the documentation, then you might be taking a position or a clerk who's going to be overloaded and overloading them even more. And that's why I brought up this this workflow first, because this clerk then does not have to make any clinical decisions. They're just making clerical decisions, and based on the clinical lens that a counselor brings, they can decide whether the referral is accepted or rejected, the time frame by which the referral should be seen, all those clinical decisions without having to overload your clerical staff.
Steve, I'm very much familiar with this process, as I myself used to be the triage intake counselor at the mental health at Children's. So I was in that position of the triaging person. So I kind of understand what you're talking about. The question would be kind of inner, I think, Vancouver Center PFC based, what is working, what is not. Given the amount of the referrals that we receive in this center, this is almost, again, full-time position it's not something that intake counselor can handle. This looks like another position for intake counselor that should be created, intake who will be doing this triaging and clinical decision judgments. This is something I would like to bring up to our clinical management.
For sure.
And also maybe to see if something we should discuss at BPL's level. I don't know.
Yeah, no, I totally agree. And I just want to kind of bring up those two worlds to you, because I know that everybody's going to be going through a lot of change at BC Cancer, not just the counseling staff, but the clerical staff. From what I've heard already, there are some concerns about the load placed on clerical staff and the number of clerical staff available. So I want to, this is specifically the reason I brought up this way first, because it is the cleanest and it separates the clerical from the clinical. However, I do totally understand that BC Cancer Vancouver does work differently and has worked differently, and you found a way to make it work for yourselves. And that's why I did bring this up. I can include this into workflows, but I also think, it might be a conversation you want to take back to Lumi, as well as speaking within your clinical team. Because it's trying to find that balance between making sure where the clinical decisions are made by clinical staff, clerical decisions made by clerical staff, but also too making sure that people don't get burnt out.
Right.
So, and like I said, I can include these processes in your clinic workflow. My suggestion is go with the former workflow first until people are comfortable with Cerner, and then explore other avenues. But this is my suggestion. I know in the end, clinicians are going to do what works best for clinicians. So, like I said, please take this back to your staff. Discuss this with Lumi about how you want to proceed, because I think this will inform a lot of the work we're doing as we go through different BC Cancer sites as well.
Thank you.
No problem. No problem.
Stephen, can I ask a question? You, I think it's maybe a couple of slides before you generated, was it a triage list or something? Can we go back to that?
Yes.
So this, yes. So this is the combination of internal and external referrals.
Correct.
Is the clinician seeing this, or is this is clerical seeing this?
This is what the clinician sees. Think of triaging as a clinical process, and because it's a clinical process, this is within the clinician's view, also in PowerChart.
Okay, so the clerical have done all the work up to this point, and this is what finally the clinician is seeing.
Yes.
Okay, so which clinician is seeing this particular power chart? Is this are all clinicians seeing this? Because the reason I'm asking this is because we all take turns of being the triage person a morning or an afternoon. So
right.
We all need to have access to be able to do the triaging. Is this something that we all have access to?
Yes. So this list, I didn't create it, but this list can be created by clicking on this little wrench. And once you click on this wrench, you could set the parameters of what you want your list to be. So your list would be for right here is the brief intervention clinic referral triage. This is how this list is set up. You would set up your own list for patient family counseling. Whoever wanted to be able to see that list could set up that list themselves.
Oh, I see. So each clinician needs to set that up in order for them to see it.
Yeah, it would be a one-time setup.
I see. And then, but we're all looking at the same information essentially.
Correct.
Okay. Okay. And then, so if I was on triage that morning, I would be dealing with this, and then whoever's on in the afternoon would see what still has not been dealt with and has been added to.
Correct. So say, David, you're working triage Monday morning. You would just start up the top of the list, and you say you got down through 4 of these, and you triage them. When the triage clinician started working in the afternoon, they would see the next 5, what was it, 5, as well as any other referrals that had come into the clinic to date.
Okay. That was the piece I just wanted to be clear, is who was seeing this.
Yeah.
And because we all touch this, it's not just one person in our department, but we all have triaging responsibilities. So
yeah.
Okay.
Yeah. It's this list is set up. You can set it up yourself. Anybody can set up to look at what they need to triage for that day at the patient family counseling clinic.
Okay.
Yeah.
Okay. Thank you.
No problem. Scheduling, did I lead anybody wrong, or are we okay?
That's fine. You're good.
Okay. All right. Any other questions? Okay. So I also want to bring up this part in the registration field. So BC Cancer has a specific registration in that they identify the tumor group from this list, and this is a set list provided by BC Cancer. So the reason why I bring this up is if this information is in the referral info, then if the clerk was to schedule patients based on the tumor group, then they could look in this referral info tab to find that information. But as you said, not all that information is face up, and I wouldn't want people to be, having to, as a clerk, to go through the chart, trying to figure out what's going on with the patient and what the tumor group is, because that's going to be a lot of time spent. So in that case, you may want to just have the clinician do the actual triage.
Stephen, so when you talk about referral form, we're talking about PFC referral form, if it's there? Or
sorry, can you ask your question again?
When we talk about internal referral, are you talking about PFC internal referral?
This is internal. This registration actually is internal and external. So actually, this is a mistake in my slide.
But the PFC form, right?
Patient counseling form, yes, yeah.
Or is it that when patient is registering with BC Cancer Agency and as information comes in terms of their diagnosis, it will be entered by any one of the medical secretaries and stuff like that?
Sorry, I misunderstood your question. Yeah, so when the patient is registered, the hope is this information is completed. If the referral is sent, this information is not necessarily in the referral. It could be entered, it could not be entered.
Yeah.
Okay.
Yeah. Thank you.
You're welcome. The similar process, external referral without triage. In this instance, the clerk would review the work queue monitor. If the tumor location is indicated in the referral, then, and once again, this is very specific to BC Cancer Vancouver, the clerk can contact the patient and book the appointment, enters the appointment to Chatbook, and creates the pre-outpatient encounter and attaches the referral form to the pre-outpatient encounter in work queue monitor. If the terminal location is not kind of face up in the referral, then my suggestion would be to have the clinician triage. Once again, these last two workflows I've shown you, well, I know this is very BC Cancer specific and is part of your current practice. I recommend the initial workflow, the triaging workflow, just to separate the clerical duties from the clinician duties. But I also know that you receive in Vancouver Centre so many referrals and you have a process already that is working for you. So I know you want to take that back and speak within your clinician or within your clinic as well as with Lumi as well. But I just wanted to bring these two up just to kind of reflect that I am hearing what you're saying, but there is inherent risks with doing it this way within Cerner.
I hear you, and I can see both realities. Again, because I've been in that position in different location, I can see how, you see, for services where this whole situation of rejecting or accepting or needing information, which was exactly how it was set up at Children's, that made a lot of sense. You need really clinical judgment because not all the referrals will be accepted. And each one of them needed to be thoroughly read through and to make decisions. So you really need a clinician's lens into what is happening there and read through the charts and all the available information. For us right now in the Vancouver Center, historically for years and years and years, we've been able to find that balance where the clerk would be able to get just initial information about tumor site. But any clinical decisions, if needed, because majority of the referrals are straightforward going to be booked. There is no accepting or rejecting or anything else. It's very rare that we don't accept referrals because they're not eligible for us. And those are just simple consultations with the PPL. So for a clinician to spend all this clinical time on just finding information, what kind of tumor site it is on the clinical chart, also doesn't sound like a good time usage of clinical time.
Right.
So I can see both ways how the system is set up, and kind of the question that I'm asking myself, whether we're going to change for the sake of the system, or are we going to be creative and maybe finding the ways of how to do it with the system, but to maintain the procedure that was working for us for many years.
Yeah, no, and I totally understand that. Like I was saying, I kind of want to reflect what you've told me already from our requirements gathering, but also, once again, I think it's from a clinical standpoint, I just want to discuss the risks and benefits of both ways too.
Right.
So yeah.
Thank you.
You're welcome. So I'm just gonna skip through this because the same applies to the external recounter. And we'll just go to clinic design, so the day of visit. So we're going to talk about appointments actually next. So on the initial visit, and once again, this is very, very high level, the clerk will create a pre-outpatient encounter and book the appointment. For in-person visits, the clerk checks the patient in. The clinician reviews the appointment in ambulatory organizer. For a virtual visit, the clinician updates the status to arrived when the patient comes, quote unquote, virtually, just because typically that bypasses the clerk, and we need to inform the clerk when the patient does arrive. The clinician will review the chart and conduct their assessment. The clinician places any prescriptions, labs, and diagnostic orders if needed. I left that in there, even though I know this clinic doesn't do these tasks at this time. The clinician then completes their documentation, places any follow-up appointment orders. The clerk then receives the follow-up appointment requests. And for a virtual visit, the clerk reviews the ambulatory organizer and reconciles the appointments at the end of the day. So what does ambulatory organizer look like? So this is a screenshot of ambulatory organizer, and this is what you would be using in ambulatory care or outpatients. You would just click on this button right here. It would take you to the day view. You would have to, the very first time you used ambulatory organizer, set up your resource group. Currently, this is set at SPH Diabetes Resource Group. I believe your resource group is called BC Cancer, BCC, VA, PFCS group. So on the day view right here, you would see all your appointments for the day, how they are going to happen. So this is going to be a telehealth or phone. This is going to be a class. You can also look at the calendar view, and the calendar view would let you see all the schedules of the different clinicians within your resource group or your clinic. And then once you've clicked on the patient here, so say we want to see this patient and look at their chart to review it before the patient came in, it would then take us to this page after we've established our relationship, and we can read over the chart. And as a counselor or a social worker, you would have access to all this information through here. You review the chart. Or I should just mention here, if the clerk wanted to inform you how the appointment was going to take place, they would tell you in this details part here. So this is going to be a Zoom appointment. So the clerk would put this into the appointment type so you knew what was happening and when or where it was happening in this case. For the clinician, once the patient has arrived, say via Zoom, because the clerk won't know what's going on, you could just click the arrived. Now, all these other choices are here, but actually you don't have access to those choices. Unfortunately, the clerk does. From the clinician point of view, you can just click on arrived. And we use this specifically when a patient is going to have a virtual health visit. Is that correct there, Andrea? I don't believe they have any of the other choices, right?
That's correct, yes. Clinicians can only flip the status to arrived.
Correct. Okay, thank you. Now, currently, if you are going to create a follow-up order, so you've seen the patient and you decided that the patient needs to be seen again, you would put an appointment request in for a follow-up order. Now, these are all a lot of different follow-up orders for other clinicians at the heart function clinic. What we still need to decide is what appointment types will be used at this clinic. So right now, and Andrea will have more to add to the slide, I have counselor new, counselor follow-up, music therapist new, music therapist follow-up. Was there any additional appointment types at this clinic for the clinicians actually working in this clinic? Andrea, that I might have missed?
So we are reviewing these like the case codes with Joy and Lumi right now. So they'll be able to give us more information about which appointment types we need to create in Cerner, because we do have a few more than these, I think.
Okay, and then my other question as well too is a lot of these provincial resources will be working or possibly working in the Vancouver clinic. Is that correct, Vancouver?
3 out of 5, I think, work from Vancouver.
Yeah, Sarah here. I'm the art therapist, and yeah, I'm mostly working out of Vancouver at home right now.
Okay. Yes, at home right now, but in the virtual world, you see patients out of the Vancouver location. Is that?
Most of them at the moment are out of Vancouver, but they are throughout the province.
Okay, yes. So I have art therapist, Indigenous counselor, social worker, and I know she's actually considered a counselor at BC Cancer. I just had social worker written down, so this is my mistake right here. But Sanja Kwong and Kelly, I didn't have her last name.
I'm sorry, her name is Sandy Kwong.
Oh, Sandy. Okay.
Yeah.
Okay.
And she is a social worker.
Social worker. Oh, is she considered a social worker then at BC Cancer or a counselor?
Again, we all go by counselor, but then
Okay.
our education can come from either social work or clinical counselor.
Okay. So at BC Cancer, she's considered a counselor.
All of us would be referred
Yes.
to counselors, right?
Yeah. Education is social worker, title is counselor.
That's right.
Yeah. Okay. Spiritual health and vocational rehab. Was there any other professionals working with the or working out of the BC PFC Vancouver location?
The Indigenous counselor is called an Indigenous Cancer Care Counselor, and she works specifically out of Prince George.
Okay. I thought, was she a provincial resource or?
Sort of.
Okay.
She'll take calls from the provincial team as needed. The only other sort of niche person we have is, but it would be Prince George specific, so we'll skip over that.
Okay. So she doesn't see patients in the Vancouver Center.
No.
No. Okay. Then I'll make sure I'll take her off this then. Okay.
What do you think the rest of the PFC team that's on? Like, I mean, she's a resource. I mean, similar. You know, she would answer a question or provide patient support. She got a referral from the Victoria Centre this fall. So she will provide provincial support, but I wouldn't say, like I'd say all of them are not specific to Vancouver, except for maybe Sandy and Kelly, but more they're provincial. Yeah, I don't know.
Well, I think it's, and I'm not saying specific to Vancouver. I think it's more just working in this site, or has the capability, or may receive referrals and work in this site. How about that?
Okay, not working in the site.
Okay, so she's not doing any work in the site.
Well, no, she's in Prince George.
Yeah. Okay. All right.
The one person who's not on that list is the what's her title?
Shelley?
Yeah. What's the resource social worker? She's a provincial resource, and she accesses clinical records and does some clinical work.
Okay, I'll tell you her title. She's called the Supportive Care Resource Counselor.
Okay.
So I think Kelly is the one who is covering for Shelley right now. I think the reference to Kelly is that for that position.
No, Kayla Badgick.
Hmm?
Kayla Badgick.
I guess so. I see under Sandy Kwong, it says Kelly based out of Abbotsford, but basically
Is that not the social work or a counsellor who's for the Punjabi speaking community?
no, they used to have it in Surrey, but she moved on, so they don't have anyone specific for Punjabi population right now.
Oh, okay.
So I got a message from, because I realized we have 3 minutes left here, but I did get a message from Andrea that they are reviewing reviewing a lot of the provincial resources and if they're going to have the ability to work or which ones will have the ability to see patients within this clinic, Vancouver clinic. So we'll double check with Lumi, and then maybe we'll bring this back because we booked another design session, and we can follow up with this work because I know we have a kind of a set time, and I want to honor people's time today. So, besides the actual professions that you see on the screen, is there any additional ones?
In Vancouver, you're asking?
Well, that have the ability to work out of Vancouver.
I don't think so.
No, okay.
Ira, do you still have the Douglas Ozier position?
No.
No, okay.
No, yeah. Thank you.
All right. So what we'll do today is we will stop right there because we said we had the time book from 8 to 11 today. And then we will follow up at our next design session. I think what day did we put that in there, Sharon?
1 second, sorry. I don't actually see a date yet because I just submitted it on Friday, but I would think it would probably be sometime next week.
Okay. So why don't we follow up on that? We'll follow up on a time when please keep your eyes open for an invite. What we'll also do too is looking at the encounter strategy. I'm going to take that back and take a clinical lens to that and see how that will work in the future. Just to for my own sake, but also to be able to bring that back to you guys as well at that time. I realize it's 10:59 now. We did book only to 11 o'clock, so we will send that invite out to you as quickly as possible and have another design session just to continue on with this work we've done here. All right, everybody. Okay. Any questions before we head off here? No.
Thank you for all the work. Thank you.
No problem. And if you do have any questions, please reach out. I'll just put my email address in the chat box here. And I will try to get back to you as quickly as I can. All right. Thank you so much, everyone, and take care. Have yourself a wonderful Monday.
Thanks very much.
Thanks, Stephen.
Thank
Take care.
Okay, bye-bye.
Thank you.
Bye now.